Well, hello everyone, and welcome to the ABCs of MIPS, how merit-based incentive payments will impact your bottom line. I'm Carol Flagg of High Tech Answers, and thanks for taking time to join us in today's conversation. This is the first of a series of 6 broadcasts where our experts will be discussing, analyzing, and addressing your questions on the current and future state of merit-based provider payment systems. During the broadcast, you can ask a question using the question feature found on the right side of the dashboard. We'll also be addressing questions asked in the registration process, as well as conducting several quick polls. Post-broadcast, we'll share the recording of today's event with you, so that'll be delivered to you by email. And now I'd like to introduce our experts from SA Ignite. Tom Lee is the founder and CEO of SA Ignite and a technology innovator and leader who brings his unique worldview and compassion to create health IT solutions for the business of caring for people. He's been a guest on our MU Live program, and we always interview him at HIMSS each year to get his thoughts on what's trending in health IT. Beth Hauk is the VP of Client Services for SA Ignite and a seasoned expert in MU and other incentive payment programs. She has worked on both the provider side and the vendor side and is a strategist in this area. Tom, how are you today? It's Carol.
I'm real good. Can you all hear me?
Yeah, we sure can. Thanks for joining. And is Beth going to be joining us as well today, or just you and me?
I believe she will be joining soon, but I can represent her. You know, she's running a little bit late.
No worries.
Apologies for running a little.
You know, I know you guys are in California, probably stuck in traffic, but so we're here, and I think we're ready to roll. So got some polls sort of synced up, and I know for this first broadcast in our series of 6 shows, you wanted to kind of give a quick overview. Then tell me when you want to do a first poll, and we'll get rolling from there.
That sounds good. Thank you all for having us. You know, today we're really going to kind of kick off a whole series of discussions over the next several months regarding the MIPS program, or what's otherwise known as the new Medicare Part B, really part of the move to value-based payment. And many of you may have heard back in March, and then signed into law by the president in shortly thereafter. This was part of the doc fix bill, the repeal and replacement of the SGR, and it's really set the stage for the next wave of value-based payment out of Medicare Part B, and we'll show in a minute how it relates to all the other value-based programs, meaningful use, and others that you all may be more familiar with. Next slide.
Do you want to take a poll right now? I think you wanted to.
Out there, I think there is a.
Whoop. You there?
I'm sorry. Yeah, we actually are just going to go ahead and do the poll.
Yeah.
Now, Chrissy's going to go ahead and run a poll here.
We really wanted to find out. I'm going to go ahead and launch it. Using the question, does MIPS repeal and replace meaningful use, right? And the poll is now open, and you can hit yes, no, and we'll give you about a minute to answer the poll, and then we'll share the results. And so polls are coming in progress. I think, Tom, you can see where we're trending right now. 68% say no, 16 yes, and 15% not sure. So I'll wait another few seconds and give people time to respond. And then we'll go ahead and close the poll. All right, so we're going to go ahead and close the poll, and apparently 67% say no, it doesn't repeal it, 17 yes, and the remainder are unsure. I'm going to go ahead and close that poll. And you can now see that the answer to that question is no.
Yes, that's great. I think it shows that everyone is getting more and more educated about what MIPS is, and indeed MIPS actually overlays and essentially reaffirms meaningful use, PQRS, and the value-based modifier programs in terms of giving really a multi-year roadmap for how these programs all relate. So you can see from the diagram that MIPS actually defines a point score from 0 to 100 that is composed of 3 parts, up to 25 points of which is due to your meaningful use performance, 60 points due to value-based modifier, and which actually inherits from PQRS, and then clinical practice improvement that encompasses things like patient-centered medical home and other areas that will be further defined by CMS as they actually go into the rulemaking process. So the bottom line is that really these programs in that bottom layer there are largely preserved. In particular, the rules that make them fairly complicated are actually becoming more numerous and really increasing in complexity now that there's another layer on top, which is MIPS. And the rulemaking will also specify in more detail how those points in each section are going to be accumulated so that you could actually end up with a single score 0 to 100 for each of your Part B providers. That will also be publicly available on the Physician Compare website a few years from now. All right, the next slide. All right, so one of the biggest questions around MIPS is, what are the potential financial impacts? And the one area where MIPS really does consolidate things among the 3 programs, MU, PQRS, and value-based modifier, is really consolidating their incentives and their penalties. And really it starts with the 2017 performance year, and there's a 2-year lag between the performance year and when the actual payment adjustment year, so that's why you're seeing the years here start at the year 2019. And just focus on the left column for the time being, is that there is a performance threshold that CMS has the ability to actually change the number of points that represents that performance threshold on an annual basis. And depending on how many points it is, let's say for example, if it were 50, then what you can see is that if a practice has a score of 75, that is halfway between 50 and 100, then in 2019 they would get 2% incentive because that's halfway between 0% and 4%. Now in 2022, that payment year, the max is 9%. So in that year, a physician that was had 50 points on the MIPS score would get 4.5%. So what's interesting is that it's a linear scale, which is unlike meaningful use and value-based modifier, which are basically stair-step functions. As a BBM, for example, is if you cross over a score of 1, then you suddenly get an incentive. There's no linearization between 0 and that top end incentive. Okay, and then the same on the downside. If a practice is at, let's say, 25 points and 50 is a performance threshold, then they're going to be in negative territory, roughly halfway between 0% and minus 4%. All right, next slide. And keep me on track, Carol.
I will do. The key takeaways. Well, I think when you talk about this, I'm starting to get some questions on MU and PQRS. It'd be interesting to take a couple polls to find out who's represented from the audience.
Sure, sounds good.
Yeah.
So, really the bottom line is MIPS is the new black, if you will, regarding value-based payment. And it really encompasses and embraces meaningful use PQRS and value-based modifier. The other part of it is that MIPS and the entire doc fix bill was passed with a huge bipartisan margin. It was well over 90% of Congress and the Senate that passed it. And what that really means at a higher level is what you might term the value-based revenue cycle, as opposed to the traditional fee-for-service revenue cycle, is really here to stay. And many of us and you all in the audience have been living the meaningful use version of the value-based revenue cycle for a number of years right now, whereby reimbursement and incentive and penalties are tied to certain definitions of value or what makes a high-performing provider as mandated by regulation. And really MIPS is just a further stamp of approval that that is going to be the long-term roadmap, certainly from the Medicare Part B side and the Part A side, inpatient side, there's similar kind of analogous movement and momentum in this area.
I'm going to go ahead. I'm sorry?
Go ahead. Oh, yeah, sure.
Yeah, I'm just curious to, again, we're starting to get some questions, and I'd be curious to see who some of these departments and organizations are responsible for MU, since these are starting to roll in, and so we're going to get to your questions just in a little bit. So I'm going to go ahead and launch the poll, and the poll's in progress, and if you could self-identify which department your organization handles MU compliance, that would be really interesting. So leave this open about 30 to 40 seconds or so. And Tom, you can see where it's trending, correct?
I am looking for that, but I will also wait for the verbal result too.
Yeah, it looks like right now, you know, yeah, 22% compliance. So we'll finish this up here in just a few more seconds. Give attendees plenty of time. All right, I'm going to go ahead and close the poll. And it looks like 22% IT, 19% compliance, 29% other, 1% finance, and 20%, at least for this audience, not applicable. That's kind of
that's great diversity, and I
yeah.
think what it reflects is that whether it's meaningful use, whether it's MIPS, whether it is more generally the value-based revenue cycle, it really crosses functions, and it's getting more and more cross-functional as the impacts really reverberate throughout the organization in terms of what an organization has to do in order to perform well, not just financially, but also in terms of the public profile of its providers, in that almost all of this quality data within the MIPS program is going to be publicly reported through CMS and other third parties. And as consumer-driven healthcare really takes over, it really does affect many areas, including the marketing department too, of healthcare organizations.
Pretty much everybody, right. And you guys wrote a great synopsis, sort of giving a review of this on your website.
Yes, we were fortunate to have the ability to really look through the regulation very closely soon after it was passed and up to when it was when it was being drafted, and welcome everyone to go on there and let us know if you have feedback or other questions after you take a look at those FAQs. It's fairly extensive, and we hope that you enjoy and get some value out of that.
And we sent a PowerPoint to everybody because we're starting to get questions about that as well. That will include the charts that Tom reviewed, as well as this is linked so that you can go directly to SA Ignite's website and see the review of that. It's terrific. And for those of you who just want to copy and paste or put in your browser, here is the actual URL to that particular article on SA Ignite's website. Before we get into the Q&A, I thought we'd take one more poll just to find out from a PQRS standpoint, because we are getting a couple questions on that as well, sort of self-identify from this audience, if you can, what department in your organization handles PQRS. And so we're starting to get in. The polls in progress. I'll give it about 30 seconds. And Tom, while we're waiting for this poll to close, I remember when we were at HIMSS, obviously, when this news sort of broke that this was happening, and I think that at least for the people at HIMSS, it was a welcome message. At least that was my take.
Yes. It's always good to have clarity, particularly clarity like this that extends out over several years. And on the other hand, we also know that annual or even monthly adjustments can also happen along the way. So it's certainly something to stay on top of. And as the rulemaking really unfolds, I think the community at large will have an opportunity to express concerns directly to the regulators. And we can try to leverage what we've all learned from things like meaningful use in terms of how MIPS ultimately gets implemented.
Yeah, as somebody, I'm closing the poll right now and just sharing the results. 8% IT, 4% finance, 21% compliance, 39% other, 27% not applicable.
Absolutely.
All right, so we've got a bunch of questions queued up from the audience, and I'm going to just go ahead and dive right in if that works for you. The first is a question related to meaningful use, and that is just some clarification. Are points applied on a pass-fail instead of a level of performance for MU?
So in terms of the MIPS piece, that has not yet been defined by the regulation. What the regulation does say is that MU will make up to a maximum of 25 points out of the 100. And there's also there's discretion to also tune that maximum down to as low as 15 points if the Secretary of HHS determines that meaningful use compliance is high enough, in terms of what. But the actual relationship between, let's say, percentage compliance or the number of providers you have compliant or percentage providers you have compliant with, whether you get 25 points or something less than that, that still has to be defined.
Question, how can providers both capitalize on reimbursement opportunities and increase access for patients? Basically, if you could sort of talk a little bit about the overall benefits for providers of the MIPS program.
Sure. And one way to look at access is really, what is the patient experience from start to finish, from the intake process to the payment process through all after the visit. And although MIPS does not directly have a major category of points, that by itself really measures patient access, for example, portal access. But however, those elements are certainly within the component programs. Obviously, the parts of meaningful use that really focus on patient engagement, patient access to information, communication with patients, those things are all going to really persist. And again, really, MIPS really reaffirms those principles of meaningful use, and providers will still be held accountable to those. Did that answer the question?
Yeah.
That was the one I decided to take, yeah.
I'm just going to go back real quick to the MIPS score, because we've had a couple people ask if it is really possible to hit 100 points, and sort of relating to your MIPS score on your chart here. Can you score a perfect score?
This is a great question. I think it's like anything else. I think back to my days in college or maybe in high school when I was able to get something close to 100. One thing that the legislation does say are that there are some of the subcomponents of MIPS, such as the clinical practice improvement category that's worth 15 points, where the legislation does say that if an organization, for example, has achieved a certification such as PCMH, but again, in the regulation, they have to define whether for sure PCMH would do this, then the practice would automatically get the maximum 15 points for that component of MIPS. Whether a perfect, how hard or easy it is to get a perfect score in the other areas, VBM or meaningful use, that kind of remains to be seen. Although both those programs have been really binary in nature in terms of meaningful use, you're either compliant or you're not. Value-based modifier, you either are going to get an incentive or not, or you get a penalty or not. There's no in between. But we still have to see in actual regulation whether they're going to smooth those things out, or whether they're going to keep it binary, in which case it would be a lot easier to get a perfect score of 100
Right.
if you also got the full 15 on the practice improvement category.
You mentioned VBM, the value-based modifier. One of the listeners wanted to know how is that calculated, and what do providers need to do? And then another third part of it, his question is there a percentage of PQRS they need to report?
Yes, with respect to, well, let me first talk about the VBM program.
Yeah.
In terms of how the VBM point system that everyone has seen on their QRUR reports from CMS, how the VBM point system relates to the MIPS point system has yet to be determined, but will be determined in the rulemaking. But if you look at VBM in isolation, just for the moment, really the way that providers need to measure themselves is against the national benchmarks for PQRS performance that are released by CMS on an annual basis for quality performance. And it's actually something we've undertaken here at SA Ignite, is that basically we can actually calculate predictively what your VBM quality score is going to be. In other words, what your QRUR will be based on your year-to-date performance. And we're doing it for a number of clients right now. And that's really the way that you need to start, is by looking at how your measures relate to those benchmarks. In terms of the cost component of VBM, a lot of that is really around what is the ability of your financial systems to give you some predictive control and visibility into your Medicare Part B billings. And there are also benchmarks for that CMS has published, and you can even see on your QRUR reports that give you a sense for whether you're above or below the national benchmark, whether it's spending per beneficiary, whether it's spending for different chronic conditions, different aspects of that. Now, in terms of how it really relates to MIPS performance, VBM does take up the largest chunk of MIPS, which is up to 60 points. And it's certainly consistent with the increase in the value-based modifier incentive and penalty range that's just even happened with this year, doubling from what it was last year. So it's a really good place to start, is to try to get a handle on your VBM, because that will also take you quite a ways in terms of making sure that you'll do well on the MIPS program once it starts in 2017.
One of the attendees just chatted in real quick. Obviously, we're talking about Medicare Part B. Wanting to know if there's any thought or what might be happening with Medicaid. Of course, there's a Medicaid part of MU, and if that will remain a parallel program. Of course, the Medicaid MU program goes through 2021, so it has a longer tail than the Medicare MU. So.
Yeah, that's actually a good, useful point even for Medicare MU, because what MIPS does not do is it does not consolidate or replace the meaningful use incentives, for either Medicare or for Medicaid. For MU, MIPS only consolidates the penalty side of MU, which is only applicable to Medicare, and Medicaid doesn't have a penalty side.
Right.
So it's business as usual for Medicaid MU incentives.
Right now, anyway. Right. Yes. Yeah. Right now. Yeah.
Exactly.
So somebody chatted in. Do you think the 2015-17 MU model will be out by July 4th? Is that what you said? What I've been hearing, and certainly what our MU experts believe, is the NPR. The notice of proposed rulemaking to modify stage 2 and for stage 2 requirements were released right before HIMSS. The comment period ended mid-May. Usually they take 60 days after that, which pushes it to mid-July. So we're sort of all thinking, and Tom, let me know if you think differently, but we're sort of all thinking that the requirements to modify stage 2 MU, which is the 2015 edition, and finalize stage 3 will probably come out the week, maybe 2 after July 4th.
Hi everybody, this is Beth.
Hey Beth.
Definitely some of the Hi.
Hi.
Since I get to carry the community burden, I shouldn't say burden, but since I carry a lot of the MU practice here at SA Ignite, I'll just, I guess, reinforce what you said, Carol. I hope that it comes out in July. I love for it to come out sooner, as I'm sure many of the folks that are on this phone. Um, I think what we're hearing also a lot of questions about is just, do we have any insider thoughts about, how close it's going to be to the NPRM, and what if it's not going to be close, what things might change. And
So speaking of timeline and calendar, Tom, you brought this up initially. Just clarification. So does MIPS? So MIPS does not start until 2017 reporting year. Does that mean payment is not affected until 2019?
That's correct. There's the same 2-year lag as there currently is with value-based modifier, as well as the outside of MU, 2-year lag. So really, next year, 2016 performance year is kind of that last year where it's truly fully business as usual with respect to how the programs are currently designed. And I suspect 2016 will be the year where the rulemaking for MIPS is going to be most active, which I think is wonderful, the fact that we're now having this type of discussion on a monthly basis with you all, because I think the more that we can collectively draw on our past experiences and influence that rulemaking process and really talk about MIPS, right? What would it actually, how would it actually impact? How would we not want it to impact us? We look forward to having that dialogue with everyone next year, because it's going to be fairly intense and important for the following 5 to 10 years after that.
One of the attendees on the broadcast today wanted to know, providers have the option to engage in MIPS or to sign up with APM program. Won't the existence of MIPS drive folks to APM? I'm actually not sure what the acronym APM stands for.
Yes, this is actually number 5 on our FAQs.
Number 5. By the way, that is linked. Yeah, so click there when you get the PowerPoint, folks. Yeah, number 5.
Exactly. APM stands for Alternative Payment Model. What it really is in the MIPS program is an additional incentive of 5% for organizations that participate in programs such as the Medicare Shared Savings Program, ACO, MSSP ACO, Healthcare Quality Demonstration Program, and probably other programs that will be defined by the Center for Medicaid and Medicaid Innovation, or otherwise known as CMMI. And I think it's great to see that they're encouraging organizations to really be part of that important work to really find the better models, and they're also recognizing with a 5% additional reimbursement that there's also financial risk to these organizations.
Mm-hmm.
As they try to embark on those paths. So that's what APM is, and you can see it on our blog post, and there's also some references that we can provide too if you want to learn more about how it might relate to your MSSP strategy and your financial model. It's definitely good news.
So just for our audience, we've got a lot of questions pouring in. Obviously, the rulemaking for the program just came out a couple months ago, and of course, people want to know what it is and all that. If we don't get to your question, because again, we do have quite a few, obviously I've put Tom and Beth's email up on the screen, and feel free to reach out to them, and if we don't get to it, but we're going to try to get to all of them if we can. Talking about performance threshold, I'm not really sure in the NPRM what was identified, but attendee wants to know, is any information about the performance thresholds been released, and will levels be 15, 25, 40, 60, 75, or 85? Wanting to, I guess, identify how big of a bar they might have to jump over.
And Carol, I'm interpreting that question as in relation to the table that we showed before.
Yes. Let me go back to that table. Yeah.
That up here.
Let me go back there.
What's interesting about MIPS that is different from something like value-based modifier is that it is not a stair-step scoring tiers. It's actually a linear scale that is where the midpoint, where you're at neutral payment, 0% is exactly at the performance threshold. So that example I said before is if CMS decided in a given year for the performance threshold to be 50, then they will set that PT equal to 50. And it would only be if exactly you're at 50 points, okay, that you would have no impact to your reimbursement. If you are 51 points, you're going to be 1/50th of the way between 0% and 4%, for example, in 2019. Okay, you'll be 1/50th of the way to your maximum. Really, it's interesting that you'll always be able. There's no safe harbor fat middle you can hide in. Okay, like you can in value-based modifier, where the fat middle is point spread of 2 minus 1 to 1. In that area, you're going to be fine. If you're minus 0.99 or plus 0.99, you'd be the same. MIPS drastically changes that. It makes it into a line instead of a staircase, a ramp instead of a staircase. So there really are no hard thresholds. It's really all linear. There's some threshold at the bottom scale, but that's more for very low performers. Other than that, it's all linear.
Right, right. Somebody asked a question. I've seen some summaries saying that an EP could get 3 times the maximum incentive, plus 27% in 2022, because this is supposed to be cost neutral, and there was 500 million extra incentives for higher performances. Can you discuss this?
Yes. One piece of detail that's hidden in this table is that there is a principle of budget neutrality, meaning that that this was a condition of the bill being passed, whereby the total Medicare spend on Part B nationwide as a total sum should not change because of this program. And what that means is that the program is taking away from the losers and giving it to the winners. Now, if the losers total, if there's many more losers than there are winners, in other words, in terms of who's above the performance threshold and who's below, who's going to get a penalty, who's going to get an incentive, then what that can cause is that if you have fewer winners and you have more losers, well, that means the winners can get a lot more than 9% in 2022.
Well,
the station says is that at most, a ratio of 3 to 1, at most it could go up to 27%, which is theoretically possible. 27% more, but you'd have to have 3 times more losing dollars than you do winners to give from the losers to the winners.
Speaking of losers and winners, if the penalties and incentives are cumulative with regards to MU, PQRS, and value-based modifier, how is that affected? It's actually quite a long question, but how is that affected if an EP, for example, wasn't a meaningful user by 2017?
In relation to the MIPS program?
Yeah. So they're doing PQRS and maybe value-based modifier, but not doing MU. That would be a...
I see.
Yeah.
I see. So I think there's 2 parts to that. One is just looking at MU in isolation. And if we're talking about the MU incentives, as I mentioned before, the MU incentives are not impacted by the MIPS program. If we're talking about the MU penalty side, then MIPS does consolidate the MU penalties with the penalties for value-based modifier and PQRS that are actually whose total negative penalty in sum is represented by the lowest row here on this table. Okay, so I think the answer to the question is that MU performance does relate to what your MIPS score is going to be, because the rulemaking will define how your MU performance corresponds to whether you get 25 points or not for MU. But in terms of the actual MU incentive dollars that you get, or that you could still have coming to you under Medicare or Medicare, that is not affected by the design of the MIPS program. That's still going just within that meaningful use silo.
Right. I mean, the MU silo. Yeah, yeah. Well, Do you have any additional information on what is included in the clinical practice improvement for MIPS?
Yes.
Great question.
FAQ number 6.
FAQ number 6.
FAQ number 6.
FAQ number 6, yeah.
Yeah,
There it is.
there are areas. Yeah, there you go. CMS this is the section that is the vaguest in the regulation. PCMH is called out. PCMH is called out specifically. The clinical practice improvement area, it also says, the regulation also says that out of the 15 points, if you are in an alternative payment model, such as Medicare Shared Savings Program, your clinical practice improvement score at worst would be 7.5. Okay, half of the maximum 15, that you have a safety buffer below of half the 15 if you are in an alternative payment model. And I think the theory behind that is if you're already in an alternative payment model, you're already putting a lot of effort into practice improvement. And so why should you be on the hook for 0 to 15 on this practice improvement side? And CMS just wants you to make up the remaining 7.5 through other activities, demonstrating how well you're doing within the MSSP program, and that again has to be defined in the rulemaking in terms of what does that mean. Right. But other than that, some areas, monitoring population health, care coordination, there's like a laundry list of different areas, but it's fairly vague. Other than what I just laid out, it's fairly vague about what it's going to encompass. We'll have to wait for the rulemaking to tell us.
Yeah, and and of course, part of that is that this is just beginning to come and be ironed out, the details as such, right?
Yes, absolutely.
Yeah, still got some time to go. Let's see here. Have the requirements of each of the 4 domains been defined yet? And if so, can you go into that further? 4 domains.
Yes, it will pop up the table.
Let me go back up to that table.
There it is, yeah.
There it is. It's a popular table.
Okay. I believe the MU, PQRS, VBM, I believe that's what the, yeah, I believe that's what the questioner may mean by.
There we go, sorry, wrong chart, here we go.
Yeah, is it, yeah, I'm going to assume it's these domains that we're being asked about in terms of the domain requirement. Is that right? Okay. You can really see it's fairly straightforward in terms of the MU and the PQRS and the value-based modifier pieces. Again, where the part that's got to be defined is how do you get, let's say, how would you ever be able to get only 20 out of 25 on MU, right? That still has to be defined in rulemaking. In terms of the actual content, if you look at the recent and ongoing activity to further refine, and develop MU regulation, VBM and PQRS regulation is updated annually. There's no indication that they're going to stop doing that. And so I think that in many ways, those individual component programs are still going to have a lot of activity going on within their silos, all right? And it's just that MIPS is naturally going to leverage now as an overlay all the work within those silos to basically be able to give every physician that one day, if it's a consumer looking at it, they understand what 100 means because they're looking for movies using Rotten Tomatoes. You know what 100% means? Well, no one ever gets 100%.
They're on Yelp, TripAdvisor. Right. Everybody understands 100 is perfect.
I mean,
yeah.
there is an element of MIPS that is designed with the consumer in mind. Okay? It's not just a financially focused quality program. There's a reason why they picked 100 points. Because in the regulation it does say that MIPS scores are going to be publicly reported. And it says the time frame too. I believe it's within a year or two of the first performance year. So basically around the first payment adjustment year, 2018, 2019. I'd have to check again. But that adds an interesting twist. In fact, value-based modifier really has that issue as well because there's this tension between where you focus your quality efforts, perhaps for internal reasons, versus knowing that those quality efforts will result in a certain set of quality measures, which may also be publicly reported. And what you want to do internally from a quality and cost perspective may be different from what the marketing department wants the image of your organization to appear publicly, at least at any given instant of time, right? And there's this balancing act between those two forces that really crosses essentially all of these areas here that we're looking at here. And really you got to think of it all in an integrated fashion, which is why I'm so delighted that we have such a broad range of different job titles here
Right.
in the audience today. Is really you have to really look at it from multiple dimensions. Otherwise, you could really get kind of unintentionally maybe detrimental to your organization.
Right, right. And you touched, you mentioned this briefly maybe 10, 15 minutes ago, but somebody kind of chiming in, is MIPS going to be budget neutral, quotation marks, like the value-based modifier program?
Yep,
yeah,
it is.
Yeah, you said
that.
that.
Actually, question exactly, the 9% could end up being 27%,
right,
theoretically.
Right, theoretically, right. We are sitting at June 18th, and there's a PQRS deadline coming up June 30th. Start talking about the current program. Can you talk about the importance of that decision, and then what the next step we should take to prepare reporting in 2016? So obviously we have a deadline coming up pretty quick here for 2015. What should providers be doing to prepare for 2016?
Sure. Well, there's really two answers. One is an answer looking at there's only 12 calendar days left.
Yeah.
The other answer is with the benefit of more time, such as next year, 2016 GPRO decision. Let me first give the second answer in terms of if you had more time than the 12 days. The bottom line is that the method decision can have a drastic impact on what your value-based modifier score is going to look like. In the field, there are examples where, for example, picking an individual PQRS reporting method versus using GPRO can actually cause your value-based modifier payment to change. That you could go from the sweet 0% neutral zone into either the positive or the negative. And it's not always the case that GPRO is better than individual provider or the other way around. It all depends on what your data looks like. And also what measures you select is also very important. That's really the kind of the scientific way of doing things. We are actually doing that for a number of our clients right now, and it's having a lot of great impact. But that's the ideal scenario with more time. Now, with 12 days left, really what you want to look at are just gotchas, or parts of the VBM or the PQRS regulation that you may have missed, but that could be very germane. So for instance, if you're if you're thinking about GPRO, for example, and you have multiple ambulatory EHRs being used by your providers that are part of that tax ID that you're thinking of declaring GPRO for, and in addition, you're thinking of using GPRO EHR Direct, which is essentially the electronic way of reporting for GPRO. Well, if you have multiple EHRs, what you will need to do is to actually merge your data at the patient level among different EHRs, and then produce only a single QRDA or a single GPRO file. Okay, and that could be very cost prohibitive, even though on paper it may seem very attractive. All right, and so that's a regulation combined with practical reality. There's another example is that this year for any GPRO that has more than 100 physicians, that GPRO is required to contract with a CG-CAPS for PQRS patient survey vendor, and something that CMS subsidized last year, and this year they're no longer subsidizing it, and that could be in the tens of thousands of dollars of additional spend for that patient satisfaction survey if your GPRO creeps over 100 providers. So if you have a TIN that's at 95 providers you really want to be very sure you don't go over that 100 mark, before June 30th. Otherwise, if you go G-Pro, you're going to have to incur that cost, unless you're on the path to do CG caps anyway. The other thing to note is from a budgeting perspective, CG caps for PQRS is a particular flavor of CG caps, and your patient sat vendor may or may not charge you incrementally to do a PQRS flavor of CG caps versus what you're already paying them for the CG cap survey, the generic CG cap survey. So those are really two different products, and you got to just make sure you budget and you understand what that can entail.
Right.
There are many other little kind of mosquito bite things like this. I'm borrowing a phrase from Beth that she's used quite a bit, and maybe you've heard on the MU side. There are lots of mosquito bites, but some of them you can prevent between now and June 30th. If you really engage some people who've been down the path, send us some emails. We'll see what answers we can provide you. But looking forward to next year, really, it's all about really monitoring your performance and seeing how they rank relative to national benchmarks. Ultimately, that will tell you better next year what method you should use to give you the best result.
We still have a ton of questions pouring in, and we definitely will not get to all of them. In fact, I'm going to ask one more before we sign off. But if we didn't get to your question, please reach out to Tom and Beth. Lots of questions related to PQRS reporting, where people are in a certain stage for MU, some questions from hospitals. So go ahead and reach out directly. They will answer your question. But I do want to ask one more, because the only one I saw related to ACOs. So for providers that participate in MIPS under an ACO, how will these providers be affected? You're a provider in an ACO.
Yeah, by ACO, I'm going to scope it down to the Medicare Shared Savings Program, MSSP ACO.
Yeah.
So there's two major ways. One is the alternative payment model, the APM bonus, the 5% bonus, that would be available for organizations. And again, as finalized by the regulation, but it's finalized by the rulemaking, but it's actually in the regulation, specifically called out that is considered to be an alternative payment model, and thereby that 5% bonus is on the table. That's the first way in which it's that ACOs are affected by MIPS. The second is really indirectly by virtue of ACOs being considered an alternative payment model, an APM, then really having in the clinical practice improvement category those 15 points, that the worst you can then do is 7.5 points. You cannot do any worse than 7.5 points, just by virtue of being an APM, and one way to be an APM is to be an MSSP ACO. Those at this point, those are the two primary ways that the legislation has outlined. But when they go to do rulemaking, there could very well be other areas of interaction between the ACO program and MIPS that they have CMS has the wherewithal to define further.
Well, alrighty. So we are actually at the top of the hour, and again, just to reiterate, if we didn't get to your question, and there are many that we did not, please email Tom and Beth directly. We will be setting up our next broadcast in the month of July, and hopefully we'll know more about, or have better understanding, timeline for MU, and we'll see whose number comes in on that. Tom, Beth, thank you so much for taking your time. We're excited about talking about MIPS for the next 6 months. It's going to be interesting and challenging, and we look forward to it.
Sounds good. Thanks for having us.
Yeah.
Thanks, Carol.
You're welcome. And just a reminder, everybody, again, for chatting, we'll get the recording and a copy of the slide deck out to everybody. Thank you for your time, and we'll see you next month.
Bye-bye.
Bye.